Good to see everybody. If people need to stand up and get a quick stretch in or move around for a second after hearing that great lecture before we talk about kyphosis for a little while. Also, if you're available to, if you want to turn your video on, that's fine as well. I hope people got a chance to look over those two articles about kyphosis this week. And we'll start off by saying, does anybody have any questions or comments or experiences with these patients that they want to bring up? Otherwise, we'll start going through the actual papers themselves just to do an overview of the kyphosis. So any comments or questions right off the bat? Anything you guys find interesting or problems you've seen? Anything at all? Also, feel free to unmute and make comments. If you want to go through the chat room as well and type questions, I'll read them off as we go through as well. So either way, just let me know what you're thinking. All right. So I guess first question is, has anybody taken care of these patients? I know scoliosis is a little more common than kyphosis, especially the bigger curves. A lot of people have kyphosis. They don't know about it. They're not symptomatic from it. It borders on just being a little hyperkyphotic above what the normal sort of curve is at about 40 degrees. And so I do think, as with other groups that we've talked to and in our practice as well, the amount of kyphosis operations we do is probably 1 out of 10 compared to scoliosis patients. So maybe 10 scoliosis patients you operate on compared to 1 kyphosis patient as far as overall numbers go. It's just much less. Has anybody seen these patients or taken care of them? Can everybody hear me all right? Give me a raised hand or a thumbs up or a chat. Okay.
Hello, Prof.
Can hear you, Professor Chris. In my practice here, I've rarely seen these cases, the kyphosis patients. Majority of patients who are coming are adolescent idiopathic scoliosis.
Yep.
I don't know about others.
Eskinder had their hand up.
Hello, Prof. This is David from Rwanda.
Mm-hmm.
I also see some of them, especially post in tuberculosis.
Mm-hmm. Yeah, we'll talk about Sherman's kyphosis a little bit today, but a lot of the principles of Sherman's kyphosis can be applied to post-traumatic, post-infectious with TB. Those are the main ones that I know that people in your center see more than others. But in thinking about what levels to choose, what type of surgeries to do, things are very similar across the board. It may just be a difference of what pre-treatment to do and what indication for it as well. Okay. Good, then I'll share my screen to start just the conversation going. We'll go through those two papers, which covers a lot of information. And the reason that I chose those two is because they cover kyphosis, and especially Sherman's kyphosis, in all different ways. So they look at maybe what the pathophysiology is, why does it happen? They look at the natural history of it, about if you do surgery, if you don't do surgery, what happens? They look at some bracing questions. Does it work? Does it not? They look at surgery, saying, do you have to go anterior or posterior or both? And then they look at choosing levels and saying, what's the best way to prevent complications? after having talked about what those complications are, because obviously anytime we do surgery, we expect and we hope for a good outcome. And I think with choosing your patients correctly and having the skill set, that's what will happen in the vast majority of the time. But when we look at operations, we have to be clear with our patients what the complication rate is and what does that mean as far as what their long-term outcome could be. So I'll share my screen here. And I think, okay, everyone should be able to see that. Do you see my mouse on the screen?
Yes.
Okay,
That's it.
perfect. All right, so we'll go through those two papers, those big overviews, and we'll talk about the different concepts in them. What topics do they bring up to think about when you're taking care of these patients? And we'll also look at the papers a little bit about how they differ and what their goals are. One was a systematic review looking at every essentially piece of literature on the topic, and the other was more of a chapter, a book chapter, looking at one specific topic and then discussing it more in terms of pros and thought behind it, not necessarily looking at every paper that's ever been published on it. So to remember back to with Sherman's kyphosis, and again, a lot of these, not the criteria, but a lot of the concepts applied to post-kyphotic deformities in laminectomies and in traumas and in infection. But Sorensen in 1964 talked about Sherman's kyphosis. Hyperkyphosis, just like Dr. Lenke said, above 40 degrees is generally more than what we consider the normal limits. When we look at the MRIs or the x-rays over here, we look at the end plates, we see that they're not straight. There's irregularities to it, and that likely has something to do with different growth of the vertebral bodies and something that the patients are born with. And we talk about Schmorl's nodes, which don't necessarily need to be fixed, but it just shows that there's differences in the end plate, meaning that the Schmorl's node is a piece of the disc that has gone down in the end plate because there's a weak spot on the end plate and the growth plates of those vertebral bodies. More importantly, and when we talk about Sherman's kyphosis, I think this is on the quiz as well, but it's wedging of 5 degrees in 3 consecutive vertebral bodies. So how do you measure wedging? When you look at the MRI here or the x-rays, you pick a normal vertebral body and draw a Cobb angle from the top of the bone, one angle, and on the bottom of the bone. And the vast majority of these are nice and square, so that angle is actually 0. They're parallel to each other, and it keeps going out. When you look at these vertebral bodies at the apex, you can see how it slopes down a little bit and slopes up a little bit. And this is definitely more than 5 degrees of an angle when you look at that angle, and these 3 as well. And so it's a combination of the vertebral bodies not growing as well on the front compared to the back, and then a combination of the wedging on top of each other and gravity pushing down in this direction that causes the curve. So it may give us some indication of why this happened in these patients, but when you look at Sherman's kyphosis like this curve is definitely more than 40 degrees. There's irregular end plates on the bones. You can see it's not a nice crisp line. And there's wedging. This is angled down, this is angled up compared to these nice square vertebral bodies. So when you look at Sherman's, that's the idea behind it. We're going to talk about this systematic review, just going through everything with big pictures. And what did they do here? They looked at the literature on Sherman's kyphosis for many different things: treatment, correction, outcomes, and changes with treatment over time, from papers from 1950 to 2017. And so that's interesting because when you think about this, we were doing surgeries definitely in a different way in 1950 compared to what we're doing now. Even Dr. Lenke said things may change in the next 10 years. They've changed for him over 20 years. And so when you look at papers that are 60 years in total, sometimes it's hard to combine those because the patients are different, the imaging is different, and we treat patients differently. But this is what is out there in the literature. So this is what that we try to combine. They looked at overall 45 studies, which is not a lot over 60 years if you think about it, at less than 1 a year. And indications for surgeries. Why do we do surgeries for these patients? Mainly it's for pain. Unlike adolescent idiopathic scoliosis, which tends to worsen over time, and we do it based on the radiographic images alone, Many of these patients come in with low back pain and upper neck pain because they're compensating for that thoracic curve, and their lumbar spine is curving in to try to compensate for it, and their neck is curving up to try to compensate for it, and they get pain in the top of the spine up here in the neck and in the bottom of the spine down below. Why also do we do it? Because some of these kids have a big humpback, and they notice that and they get made fun of for it, and it's causing problems with how they stand and how they sit and how they wear clothes, and also it causes some pain. There's also patients who have had pain and who underwent bracing and therapy, and that didn't work. And if the curve is big enough, we progress to surgery. And there's rare situations where the spinal cord is being pressed on. That's pretty rare in these cases. When they look at the surgery, the average was about 56 or 76 degrees. So we're talking about big curves here. I know he said 40 degrees is the normal limit, but the ones that end up with surgery are much bigger than that. So it would be unusual to operate on a patient that has 50 or 55 degrees of kyphosis. It can happen in certain situations, but these are generally larger curves. And the ones who usually get surgery are older patients because they've gone through their growth spurt, they have more pain, and it's larger curves and more rigid curves. If it's a flexible curve, sometimes physical therapy and stretching will help. You can elongate those bones and the muscles, make them stronger and hold them upright. Or you can get a brace that pushes you upright if it's flexible. But if it's fixed, no matter what you do, that curve cannot change. And so it's harder to do it without surgery if it's a fixed curve. Magogo or anybody, when you see these patients, where do they usually complain of pain? Or have you seen ones that have been bad enough that had complaints? All right. Well, we'll continue on then. Yeah, go ahead.
Yeah, some of these patients, they usually complain of low back pain and neck pain. For a few cases that I saw.
Yeah, and that.
This is,
yeah, that's the most common place for these, which is different than adolescent idiopathic scoliosis patients. Whenever they're in their teenage years, many of them do not complain about pain at all. It would be unusual. In fact, if they do complain about significant pain, that's whenever you start looking for other things, such as tumors or a syrinx or a Chiari malformation or tethered cords or a bulging disc or something like that. And so those patients, we mainly operated on what their imaging looks like. And kyphosis patients, if you have a 70-degree curve but no pain, we're probably not doing surgery on you unless there's other reasons. If you have a 70-degree curve, kyphosis curve, and you have terrible pain and exhausted conservative measures, those are patients that we start operating. And so how do we approach that? Mainly from the back. In the old days, before posterior instrumentation, people would go in from the front. And so when you think about a hump and a curve, there's two ways of straightening that curve out. You can either make the front of the spine bigger, which is going to straighten the curve out, or you can go from posteriorly and pull the spine back and compress and make it smaller. So those are your two options about physically, how are you going to make this curve less? If you go in from the front or your side, you have organs in the way. Sometimes people used to split the sternum. They used to go in from the side and move the lung out of the way. And you have different complications going in from the front. And the correction was not as good because you only did it over those few levels in the middle where the apex of the curve was. This is before pedicle screws, though. And so they didn't have good enough fixation or strong enough hardware to pull it back and withstand those forces. Now that we have those options, the vast majority of these are going posteriorly. Now, that doesn't mean that there's not problems with it. The main complication is hardware failure and junctional failure. So what does junctional failure mean? It means you put rods and screws in the back along the spine, the levels above where you instrumented and the levels below where you're instrumented. If you have falling off or kyphosis on the top of the spine, that's proximal failure. If you have hardware failure or problems at the bottom of the spine underneath where the hardware is, that's distal failure. And when you have a spine that wants to naturally pull forward and you pull it back, the forces are still pushing forward. And so that's why you have to choose your levels correctly so that you don't stop too short and the top of the spine falls forward, and then you have to go in and revise it and go higher. Equally, there's a balance. We don't want to go up into the patient's neck, or we don't want to go up really high. We want to limit what we have to do. But just as Dr. Lenke was talking about, choosing our levels are very important. So how do we avoid proximal junctional kyphosis? And this is in adult surgery, and this is in pediatric surgery as well. If you go, we look at the top of the construct and the bottom of the construct, and they're slightly different. And the second paper is essentially talking about how to choose the bottom level, just like Dr. Lenke did today. Both papers say just get to the top of where the curve is. So I'll show some pictures on the second one, but get above where the curve starts becoming kyphotic as it turns into the lordosis neck. You want to make sure you're above the curve. If you stop underneath where the curve is still going in a kyphotic deformity, then even if you pull the bottom part back, the front still will fall forward. Even more importantly, you have to be careful about what the tissues are up there. So you don't want to disturb the facet joints at the top. You want to try to leave the muscles attached to those vertebral bodies in the spinous process and the transverse processes at the top above where your fusion is. And as they talk about in this paper, maybe you don't want to correct them too much, because if you have a patient who has a 70-degree curve and you correct them all the way to 20 degrees, that's a big correction, and the residual curve at the top and the bottom may still want to fall forward. And so in kyphosis, we generally aim for about 50% of correction. And so if you've got a smaller curve, you can correct more or to a smaller level. If you've got a bigger curve, you correct down to about half that. We'll talk about the distal end later with the second paper. So proximal junctional kyphosis, the kyphosis at the top after the hardware is placed as it goes forward, is a big issue. And that's the main issue when it comes to this type of surgery.
Sorry for interruption, Professor
Yes.
Chris. The first lordotic, go to the last slide.
Yeah.
Does that mean the neutral vertebral body? The one not in the curve.
It's not neutral as much because there isn't side-to-side rotation with it, or they're not generally speaking one higher than the other. We'll talk about this. I'm going to show you pictures because the whole second paper is basically based on the distal construct. So we'll talk about first lordotic level, and we'll talk about the sagittal stable vertebra, which is drawing a line up from S1 and seeing which bone that it crosses over. And I'll show you pictures about that on the next one.
Yep. Okay.
When we look at papers, and this is not just this paper, but every paper that you read, you have to decide, was it a good paper? Should we take what they say and apply it to our practice? Just because it's in a journal doesn't mean that they did a good job putting it together. There are problems with papers, or maybe it's good talking about one specific thing, but you can't then generalize that to other patients or other procedures. So what are the problem with this paper? There's a lack of level 1 and level 2 evidence. And what are level 1 evidence? That's a randomized trial. It's a double-blind trial. It's generally in medicine procedures where you're giving people a placebo pill or a blood pressure medications, and nobody knows which is which. And you follow those patients through and see how they do. It's really hard to do a randomized controlled trial in spine surgery or orthopedics or neurosurgery, because it's hard to randomize them. If you think the patient needs surgery and is going to have a problem if they don't get it, then it's probably not right to withhold that treatment from the patients. Furthermore, it's hard to do a randomized trial because you either do the operation or you don't. And everybody knows if you got the operation or not. So you can't blind it as much as well. So there's other issues that surgery doesn't translate into level one studies. But we have what we have, and that's mainly case studies where different institutions look at all their cases and focus on that, or you combine multi-centers together to get your studies. There's not data for every patient. So even though there are 49 studies in there, when you combine them together, you generally use the mean and standard deviation of them. You're not looking at a list of all the studies from all the papers. And so it's hard to then make specific conclusions based on averaging the studies together, as opposed to getting a list of all 700 patients that were in there. They didn't look at the pelvis. And so Dr. Lenke showed you today about a thoracic curve that was corrected. He induced kyphosis in there, and that made the lumbar lordosis restore so that the patient stood up in better sagittal alignment. There were no spinopelvic measurements in any of these papers reported. You can only see what you published. There's many, many more people out there doing kyphosis operations, but they haven't published on it. And so was this just a segment, and can that be generalized to everybody? Or can we take the conclusions from this and expand it to your practice and my practice? They didn't look at any clinical outcomes. So nowhere in these papers did they say the pain got better, or the quality of life got better, or the cosmetic appearance got better. Or maybe individual papers mentioned that, but there wasn't enough of those together to draw big conclusions for that. So these papers were mainly based on Cobb angles and x-rays. And all the studies were different. So although this is a good starting point, and it shows what topics are out there, it shows what people have published, and you can make some broad generalizations on them, there are problems with every paper that's published, and these are some of them that has gone with those. So when we look at the first paper, we say surgery affords superior correction compared to bracing. That makes sense. If the curve is big and the curve is not flexible, you correct it. It's likely going to be corrected and maintain it after you put rods and screws in, compared to physical therapy, but that's only people that you need to do surgery on. Many people these days are going to posterior only fusion, which is coming along because of technology and safety. Complications include hardware failure and kyphosis at the top and the bottom, so junctional failure, and the posterior approach has gained more popularity. So we'll stop here for a quick second or a little bit for anybody that has questions about the first paper, or questions about anything that has to do with those topics in general, before we move on to our second paper. And we'll talk about distal kyphosis and choosing the level with this paper itself.
Professor Chris, what is your recommendation regarding to surgery? Do you do combined approach, anterior and posterior, or you just do anterior only? And if you compare our settings in Africa here, would you recommend doing anterior approach?
Yeah, so I have not done any anterior approaches for this specific problem. I've been part of them for bad scoliosis curves, if we need to release that because they're rigid. But for kyphosis, which is a sagittal deformity front back, I feel that the extra complication rates from going into the chest is not needed for the correction for these patients. You can do most of this with just 2-column osteotomies, which we'll talk about, but releasing some of the bones from behind. And with the greater hardware that we have, even if you don't have, as you said, in East Africa, there's less screws around. I still think that if you get good enough fixation on the top and on the bottom, that you can then pull back on the spine and it'll hold in place. Anteriorly, I just think involves too much complication rates. And honestly, you're probably going to go back in and do a posterior approach anyway. And so I don't think that you need to do both. Most people, when you look at these studies, the old ones were anterior and the new ones are posterior, especially when it comes to putting in pedicle screws.
Dr. James speaking.
Yes.
Yes. When I went through these papers, again, it looked posterior approach based on the posterior approach in terms of the stabilization. And even more recent papers more towards the posterior approach. Would it be right to say that the anterior approach is phasing out?
Yeah, I think it's fading out. Yes, very much so. We lost you, James. I think the connection is fading out.
Maybe if you can write his question on the
Yeah.
chat box.
Yeah, we're group A, right? So let me put this
Yes.
in.
Yes.
Yeah. There we go, to group A. Yeah. Oops. I said cat box. It's the chat box. Okay. All right. So we'll see if James either logs back on or if the chat box starts going. So we'll look at the second paper, which talks about some background as well, but mainly focuses on this last piece, which is selecting fusion levels. And Dr. Magogo's question will talk about that. This is Dr. Lenke's paper, so that was nice to have him on the chat today as well and to hear his experience. This looked at classification of kyphosis, the natural history a little bit, the treatment, the approach, and then more importantly, selection of levels. And so this study was a little different. It was a general literature review, not a systematic literature review. And what does that mean is that they had a question that they wanted to answer, but they weren't necessarily trying to bring together all of the information that has been published and make conclusions on that. They were going to talk about some level selection. And so they looked at papers back and forth to determine what is out there, what have other people been doing, and how does that fall in line with it. So it's not all inclusive, and it's not a systematic review like the last one. They briefly mentioned that there's typical kyphosis and atypical for Sherman's. The typical is more common. It's in the mid-thoracic spine. It meets those Sorensen criteria that we talked about previously, and especially the vertebral body wedging. The atypical, the deformity is a little lower in the thoracolumbar or the lumbar spine itself. Then they said, well, what happens with these patients? If the curves are less than 60 degrees, most of the people do just fine without surgery or maybe with some conservative measures like exercise, maybe bracing, but they do well. Okay. The pulmonary complications is only in curves, really big curves, like greater than 100 degrees. And so most of the patients that we're talking about don't reach that criteria. Sherman's kyphosis patients compared to non-Sherman's kyphosis patients. So normal patients might have more back pain, limited thoracic extension. Their back is not as flexible. That goes along with having the kyphosis. And sometimes they choose jobs with less physical activity. And we're not sure necessarily why that is, but just some studies have said maybe that's the case. They may have more psychosocial problems, meaning body image problems. When they look at themselves in the mirror, they're not happy with that, and that affects their mood. They may have depression or anxiety, and there's some evidence that shows that scoliosis patients also have these similar things. And so when we talk about treating the kyphosis and the scoliosis, you also want to talk to the patients about how they're doing emotionally with moods, with depression, how they look at their body, how they feel about that, because the worse of those situations as well, the worse outcomes even after surgery. So sometimes people need to have some counseling beforehand or to just talk about this so that people are aware that this is a concept to be treated before the surgery. Unlike idiopathic scoliosis cases who are more than 50 degrees and continue to progress, The kyphosis patients don't increase that much. When they looked at this in 46 years further into the future, these patients only progressed about 15 degrees, which is very different than the scoliosis patients who will progress about 1 degree per year. So this is different. It's more of a static process. It's more of a pain-related process than the scoliosis, which you do surgery to prevent the future problems, and mainly in patients who don't have pain. And again, neurologic defect, compression of the spine is pretty rare. So similar to what we heard from the first paper. What do you do for treatment? There's less criteria. In adolescent idiopathic scoliosis patients, as they get to that 45 or 50 degrees, you're talking about surgery in most cases. In these patients, you could have a smaller curve that has lots of pain that you treat after conservative measures. You can have a curve that's 80 degrees and they're doing fine, and you don't have to treat with anything. And you can let that patient continue with conservative measures or doesn't need anything. So most of the time, curves between 50 and 80 degrees are non-surgical, but every patient's different. Braces in adolescent idiopathic scoliosis patients, we have evidence that braces work. It can slow down the curves, especially in patients who are young. Here, it's generally in patients with more flexible curves because maybe you can then correct them a little more, and then the gravity that pushes down or the bones don't have as much force on them, and they can become stronger or remodel. So maybe braces work in smaller curves and more flexible curves. Also, we talk about non-surgical treatment. Exercise is key here because you want to make sure that the patient's back and core muscles are strong to maybe help them support that curve so that the pain is not as bad. Also, to try to get whatever flexibility they can in their thoracic spine to straighten it up, to be able to maintain that flexibility so they don't get even stiffer as they get older. Surgical treatment like the other one, progressive kyphosis, neurologic defect, which is rare, persistent pain, which does not respond to conservative measures, and a notable deformity in immature patients who are going to get worse or who have growth left. And so you want to try, I'm not talking about 8-year-olds, but I'm talking about 12 or 13-year-olds, but patients who are still trying to correct so that the rest of their body can grow in better balance. So similar to what we talked about. Again, no consensus cutoff. This is more by symptoms and overall discussion with patients compared to a radiographic cutoff. And overall, surgical patients were older, they have more pain, they had lower self-appearance scores, so they don't like what they look like. And generally, they have higher BMI because I think that the more weight that the patients carry on their body, the more that gravity is pushing down on that hump, the more the hump progresses and the more pain that they get. And so part of the treatment for this is actually, if they're overweight, is to try to get them to lose weight to get less pressure on their back. And I've had a couple patients with 50 to 70 degree curves who lost a bunch of weight. They were well overweight and lost weight. And actually between that and exercise, their curves actually improved because there's less gravity and less weight on their back. And they actually didn't need surgery. So for the patients who are bigger and who are overweight, weight loss is a big deal for them. What's the posterior approach? We talked about what the posterior approach is and that people do it, but what is it? There's trends towards the posterior only approach. We talk about 2-column Ponti or Smith-Peterson osteotomies at the apex. You get about 5 to 10 degrees per level. So if you're talking about an 80-degree curve, you're correcting down to about 40 degrees. You try to spread that out over a few levels, and you maybe 5 levels of osteotomies. What does that osteotomy look like when you look over here? This is a posterior view of the spine. This is a little more lateral. And we're talking about removing the bottom of the spinous process here, removing the joint out laterally. And now you have a channel of bone across that's missing, an opening across the entirety of the back. This is your 2-column osteotomy. This is what we're talking about. And then with pedicle screws in place, you can compress those two. So you can pull those 2 screws together on the rod. You push them together, and in shortening the back, that'll straighten the spine out. And so you do this over 3, 4, 5 levels. You put screws in over the apex, you compress down, and you can correct some of that kyphosis. So just like with the scoliosis patients, you need screws at the top and at the bottom for a good base and on both sides of the hardware. And if we can get screws at the apex to compress, that's how you can use less screws, but still get good correction and good fixation. For patients who have a significant angular curve, meaning that the curve is only on one body, and this sometimes happens in trauma when one body collapses, or it happens in TB where that one infected level is compressed and the rest are okay. Sometimes you have to do 3-column osteotomies, which is where you then dissect around to the front of the bone, remove some of the vertebral body in the front as well, and then compress the whole vertebral body down. We try to avoid these as much as possible because there's a higher complication rate because you're going around the spine itself. There's a lower fusion rate because you're removing more bone, including cutting through those bodies. And so there's more complication that goes around this, and there's more skill that's needed with this. So if at all possible, and in most of these cases, you can do posterior osteotomies. You don't have to get into the vertebral body unless you're doing it for a different reason. I'll show you pictures at the end of the Smith beats. Actually, we can go there right now. Here.
Professor, please correct me if I'm wrong. So we have two types of osteotomies. Pedicle subtraction osteotomy, and the other one, which I thought like it is a vertebral column osteotomy. Am I right, or confusing the terminology? No,
you're right. So there's in the newer classification, there's about 6 different levels of osteotomies that people broke it down. And because of what you're saying, it kind of gets confusing with basically how much bone are you removing. And so let me actually stop this screen for a quick second. And I'm going to flip over to this. And this is the sort of the new Schwab classification. Schwab is a spine surgeon. And what I'm going to show you is explaining the osteotomies a little better. Okay, so this comes from their paper, and you basically decide is it an osteotomy posterior to the spinal cord, which is the 2-column osteotomies, or the Smith-Peterson or the Ponte osteotomies, all similar things, or is it a 3-column osteotomy, meaning that it involves the vertebral body and the front of the vertebral body. And it goes up in terms of how much correction you get, but also the complication rate as you go up into those osteotomies. So when we look at this, the first thing that you can do to mobilize the spine is just remove the inferior facet joint. You can take the facet joint off the side. That can mobilize some things. You're not near the spinal cord itself, and that can help with mobilization. If you look at the osteotomy that we just talked about, the 2-column osteotomy or the Smith-Peterson or Ponte osteotomy, you remove the lamina and the joints on the side, so you create a straight line across, and then you can compress posteriorly, or in scoliosis, it can rotate a little bit. So this is sort of the 2-column osteotomy. All of these osteotomies here, 3 through 6, are all 3-column. You see they involve the posterior elements, the middle column, which is the back of the vertebral body, and they go into the vertebral body all the way to the front. And this is what addresses your question, Magogo. This is a pedicle subtraction osteotomy because you remove the pedicle and you take a wedge out of the vertebral body in the front, but you leave the vertebral body alone. This is sort of a pedicle subtraction osteotomy extended, meaning it's mainly the pedicle, but you remove the disc as well. This is a vertebral column resection because you take the posterior elements and the whole vertebral body away. And this is a multi-level vertebral column resection because you take the posterior elements and 2 vertebral bodies away. So it's all on a spectrum about how much you remove. But 3 through 6 is all 3-column, the back, the middle, and the front. And 2 is just posterior. So the pedicle subtraction osteotomy is just a smaller version of the vertebral column resection. It just depends on how much bone you're removing up front. Does that make sense?
Yeah, sure. Got it.
Yep. Yeah, these pictures help out.
So this is Schwab 1, 2, 3, 4, up to 6.
Yep, you got it.
Sure.
And the vast majority of adolescent idiopathic scoliosis and the kyphosis in kids especially are these type 2 osteotomies. It's a pedicle, it's a Ponte osteotomy, a Smith-Peterson, but it's removing things posterior to the spinal canal itself. You rarely have to go in front of the spine and do those bigger osteotomies that have more complications. when we look at this again from pictures, here's to follow up on those osteotomies here. This is a kyphosis patient. You can see how deep this dives down into the lumbar spine. It comes up and over the hump, up towards the cervical spine as well. And you can see he's got a big kyphotic deformity. There are screws in the pedicles at just about every level. You can see that here's the Smith-Peterson or two-column osteotomy Ponti. And what it is the back of the spinous process is removed. The bottom of the lamina is removed, and the joints out laterally is removed. So you create a line straight across the posterior elements of the spine. There's one here. You can see one right here as well. You can see one right here as well. And there's one down here because that's where the apex of the curve is. This is where most of the curve is. And then how do you then reduce this? I basically put in straighter rods. You create rods that are less kyphotic, and these are going to bend down to the patient, but you create rods that are less kyphotic. You put them into the patient like this, and you think, how are these rods going to fit down here? Well, they're going to move down because as you push down on the rods, it brings the front or the back of the patients up. So it creates that kyphosis. It reduces it. You're reducing the curve just by pushing one of the sides down. It brings the other side up, and that's reducing it already. And then you sequentially reduce these rods down to the patient. So we start here. There's little cap screws that go in, and you push it down. And as these get pushed down, this rod goes further. You put more towers on and reduce down. Or if you don't have the towers, you have to have two people holding these rods down, and you push them down into the patient and sequentially put the set screws on, and that'll reduce. If that's not enough, you come here at the end and you put a compressor and squeeze those screws together to, again, make the back of the spine smaller. And so it reduces the curve. And so for kyphosis, this is generally speaking how we put the rods in at the end. It's a little different than scoliosis because there's no side to side translation, but you're trying to bring either the front or the bottom up to reduce the curve. And then you can do some compression on the ends. So screws at the top you need, screws at the bottom you need. It would be nice to have screws at the apex to free it up and compress. But even if you just had screws at the top and the bottom and you had osteotomies in the middle, you'll still be able to reduce this down in here, and that'll make a nice correction.
How do you pull the rod? What do you use to pull the rod down?
As far as what type of rod or what?
No, I mean, like you see this picture on the first upper corner, right corner. The rod is up. So how do you pull it down?
Yeah, you can physically in the OR. I take these rods with my hands and I push them down towards the spine, and that brings the one side of it up. You basically cantilever it, is what it's called, but it lever them. So you get them in about the screws at the top or the bottom. These are in. These are nice and solid. And as you push the one side down, the curve from the bottom starts coming up, or vice versa. You start at the top. And then if that's not enough, we have these reduction towers, things that clip on the screw heads. And what it ends up doing is you screw the set screws through those towers, and it also helps push the rod down. So you start at one end and you just sequentially put the set screws in, which will lower the rods down, with also somebody holding the rods down towards the patient. And so you march up from one side, and as you get more of the screws in, it'll continue to push the rod down.
Okay. Okay, got it.
And so now let's talk about the junctional failure question. This is what Magogo talked about. This is the main complication from these cases. I think that's also in the quiz, is what's the most common complication. Infections are low. We had talked about that, but and having some sort of neurologic deficit is also low. But having screws pull out or having kyphosis above or below is tough. So what does that mean? And what patients get this? When we originally talked about adolescent problems, such as scoliosis and kyphosis, most of the time we forgot about the patient's sacrum and pelvis. We thought it was only related to the deformity that was up top. We now realize that, like everything else, the overall alignment matters compared to just fixing one part of the spine. And so when they mention this paper, it says higher pelvic incidence increases risk of kyphosis. To review, for people who haven't seen what pelvic incidence is as much, look at this x-ray here. The pelvic incidence is an angle from the femoral heads to the sacrum and then perpendicular to the sacrum. So you can see that this is an angle, and it's the same for the patient as they are throughout life, but it's different in every patient. So every patient has a pelvic incidence that's within some range basically, but it can be different in every patient. And the reason we want to know this is because this pelvic incidence is related to what the lordosis should be. So basically the lumbar lordosis in a normal spine should be very close to the pelvic incidence. And that's so that as your hips are rotated back, your spine compensates for it, and your thoracic kyphosis matches that as well. So you stand upright. And so in patients with a high pelvic incidence, meaning that they should have a higher lumbar lordosis and a higher thoracic kyphosis, if you correct them back past what they wanted to be in the first place, their body naturally wants to move forward and is naturally fixed or is naturally pulling forward, which can lead to forces to pull out of the screws or on top. If you see a patient with a low pelvic incidence, meaning that their lumbar lordosis is small to begin with and their thoracic kyphosis wants to be small to begin with, you can correct them down to a smaller curve and there's less forces moving forward. So in general, this goes along with not correcting the curve past about 50 degrees. But if you notice that a patient should have a big lumbar curve and should have a sizable thoracic curve, then we don't want to correct past that. If you see a patient with a small pelvic incidence, which would mean a small lumbar lordosis, then you have more room to correct back to a smaller thoracic kyphosis. It's all about balance and lining up the thoracic spine with the lumbar spine with the sacrum. That's kind of advanced things when we think about this in general. If you think about just correcting the kyphosis back to about 50 degrees, most of the time you're going to be just fine. And if you pick your levels correctly, then you're going to be fine. But as you start looking into the overall spine picture, we do have to acknowledge that different patients have different baseline curves. And there's some patients who are normal with a thoracic kyphosis of 20 and a lumbar lordosis of 20 and a pelvic incidence of 20. And there's some patients who have a normal thoracic kyphosis of 40 and a normal lumbar lordosis that is bigger and a pelvic incidence that is bigger. And if you correct the one that has a 40 degrees normal kyphosis and you correct it to 20, they're going to have more complications than if you left them or corrected them back to about 40. So it's a complicated way of thinking about it because it's about 3 areas away from the thoracic spine. It's thinking about where do you want to end up by looking at the lumbar spine and looking at the pelvis as well, not just looking at the thoracic spine.
Excuse me, Prof.
Yes, David.
When you're contouring your rods, how do you make sure that you do not overcorrect or undercorrect? It's always challenging to me to know how much I'm going to contour that rod.
Yep, I agree totally. Part of it is using X-ray when you're done, so you can get a lateral X-ray if you have that, and then you can sort of measure either on the screen or in your mind. You have some idea about what a 40-degree curve basically looks like, but you can look at it and compare that to your preoperative film. So I think that's one way. The other thing is you can also, you have some idea in the OR by how flexible these things are. So oftentimes these patients get MRIs beforehand, which means that they're laying down in a supine position. So if you compare the MRI of somebody who's laying down to the standing X-rays of standing up, you get an idea about how flexible they are. You go back to that first image. So this is actually the same patient, believe it or not. So this is an MRI scan of him laying down supine. This is an X-ray of him standing up. And the curve here is about 90 degrees. And the curve here is about 50 degrees. And so I know that in the operating room, I don't have to do much more correction than get him on the table and get him laying flat. We do some But I have a good idea that I don't want to go crazy and try to correct this guy even more, because look at what he does naturally. If the MRI looks like this, or if when he's on the table, it still looks like this, then you know that you're going to have to do more osteotomies and more compression on the rods, and maybe even stronger rods to try to pull that back. And so you're exactly right. When you look in the OR, you're deciding, do I have to do all those osteotomies, or did he correct just by laying on the table and being exposed and being under anesthesia? Because they're relaxed now on the table. They've been laying flat for a while. You've dissected the muscle off, so you've loosened up all these things. And do you have to do more active stuff like osteotomies? Or can you just put them on the table and basically put the screws in and lock them in place in that way? Most of the time you need to do some correction because they're fixed in some way. But to what level is determined by how flexible the patient is. And some of that is also how old they are. If this patient is 22 years old, his curve is probably more fixed. If he's 13 or 14, there's probably more flexibility left. And that's with scoliosis as well. But you want to keep that in mind as you're looking down and doing those rods. Well, first of all, before you do that, do you have to do a lot of osteotomies or not? Because there are complications from osteotomies, and you're doing work around the spinal cord, which we don't want to do if we don't have to. So do we have to do osteotomies to correct them? And then how much do you have to force that rod in? If you have to correct them a lot, you make the rod straighter and force that rod down to pull them up. If you don't need to do that much correction, you can contour the rod with a little more curve and almost lay that rod in so it's not pulling back on the spine a lot. And so you look at the flexibility, you can look at your preoperative films, and you can look at x-rays in the OR after you're done. But in general, as you get more experience as well, you start looking at the patient intraoperatively, and in your mind, you have a better idea about how much you need to correct them. That's a great question.
One of the CMs I have can help me to measure this angle intraoperative. So I've tried to use these ones, but I was not very sure that it was an overkill. I want just to have an idea whether there is another trick that someone can use. Thank you very much.
Some of the C-arms nowadays you can actually measure in the computer. And so there's advanced ones that it brings up the image, and then you can draw Cobb angles on it. So that's sort of the newer technology. You can get your measuring protractors, where you physically put it on the screen and draw angles and measure it that way. But in general, it's not an exact science, because you won't necessarily know what everything looks like until they sort of stand upright. But it gives you a general range to know that you didn't have a curve that was 80 degrees and you did all these things, and now you're looking at a rod that's straight and all the screws are now straight in line, and you're saying, hey, that might have been too much. I need to still have some kyphosis left. But a lot of it is using the information that you have both preoperatively, intraoperatively, and then with the information with x-rays if you have it. And so it's sort of a combination of all those things. And there's also patients, you can use different types of rods. So there's different metals that are stronger. Cobalt rods are very strong. Titanium rods have a little more give to them. And so if I have a really big patient who we need to correct a lot, I'll use cobalt rods because they'll hold more. They'll bring the patient back to me a little bit. If I have a big, strong patient, or if I have a smaller patient who's more flexible, we'll use titanium because I'm worried that the cobalt, if I put it in too straight, it'll straighten the spine out too much. So different options with metals as well, the osteotomies, and also how much force you put on those rods themselves.
Excuse me, on that, does it make sense to double the rods? If you don't have a stronger rod, like I only have titanium rods, sometimes I feel like I have to double them, and I do so.
Yeah. Do you mean putting in like 3 or 4 rods? Because most of the time there's 2 rods in anyway, right?
2 rods on either side or both sides.
Right. Yeah. So you're talking about putting in extra rods, or we call them satellite rods, the ones next to it.
Yeah, sure.
Yep.
Sure.
I think that if you really think that you're losing correction in the OR, that you can't get enough, you can do that. We do that with trauma sometimes, or with infection, because if you're doing dissection into the front of the bones, then it's going to be less stable. And so we'll put smaller rods along where we do the pedicle subtraction osteotomies or vertebral column resection.
Exactly. I use it when I have to do a shrub
Yeah.
3.
Yeah,
But
exactly.
for shrub 2 or 1, I don't think it's really necessary.
Yep, I agree with you totally. That's when we use them, is for the Schwab 3s and up. If for some reason somebody has had surgery before and they've broken their rods, and we think that they just haven't fused in that area, if you do a redo operation there and you think that it needs to be a little stronger. Yes. Dr. Kabidi, do you have a question, or is it off mute by accident?
Yeah, Can you do that?
Okay.
Yeah, James speaking.
Yeah, welcome back.
Yeah, I've been around.
Yep.
Yes, Professor Lenki emphasized the need for neuromonitoring. And I'm sure you've been here last year. Fortunately, last year when you came, sorry, that was 2019.
Yeah.
But by that time, you guys came with with a neuromonitoring system at Muhimbili. But in other words, in a setting of where there's no neuromonitoring, could you still perform this stabilization? Because
Yeah.
I mean, in trauma, we basically do it without any monitoring, and it's quite easier because as a patient, some have lost any function, maybe below the with severe cord contusion. But like Professor was saying, that these are stable patients who are, and it's an elective surgery. Would you still go for a surgery if you didn't have this monitoring system?
Yeah, I think that's a really tough question, and every group has asked that. I know that's a problem. That's why I brought it up today to the group, and I think it's different in everybody's situation. So if I were doing these here and I didn't do monitoring and something happened, it would be a very bad thing, because standard of care here, we have monitoring around, and so that's what we do. In situations where you don't have it, I don't have a good answer for that, because in an ideal world we would get monitoring, and Dr. Lenke's right. There's been small curves that should have no problems with correction, but you get monitoring changes and you have to release the rods a little bit, give them more time, and then maybe you can put them in. But if you didn't know that, there could have been a really catastrophic injury where they could be paralyzed, and you didn't know that. Even if you do wake up tests, if you put the rods in and then you have them wake up at one point and they do fine, you still don't know over time, in real time as it goes, what's happening with the spinal cord. And so I think that the only thing I can say is that in an ideal world, as you start doing these type of patients, or as you talk to your hospital administration saying, this is the type of surgery we want to do, but we probably shouldn't or can't do it without neuromonitoring, it's got to be that kind of conversation that has around with it. And I've been to Africa for, since about 2012. And so I understand that there's different politics that go along with all of this when it comes to everything into the hospital. But I think at the very least, it's a different conversation that you have to have with your patients as far as what the risk is. And so when we talk to our patients, we say the rate of having a neurologic injury is very low. And we know that because we have monitoring, and we know that if we have a change, most of the time, nearly all of it, we can reverse what we do. The signals get better and we can do something different. If you don't know that, then I think you have to tell the patients, there's risk of infection, these other things, but there's also risk of being paralyzed from this. And I don't know what that rate is without monitoring in those certain situations in different centers. But I'd be hesitant to do your first few cases without monitoring, because what happens if you do come up with somebody who had a bad outcome? And then I think then most people in the hospital will say, this isn't safe, don't do it. But every center is different. And you know what you've talked about with your trauma patients. Like, what if a patient has a burst fracture at T8? They need to have surgery, but they're neurologically intact. And you're going to take that patient for some sort of stabilization if it's bad enough, and you don't have monitoring for them either. So you have that conversation with them about the surgery that they do. So this is a real tough thing, but it's part of these courses as well. And it's part of seeing these and coming in with data and information to go to your centers and saying, we can start with these small cases, but if we try to expand, or here's the data that says that the rate of the paralyzing is more without monitoring than it is without. And so you take that information to your hospital and to people who want to do the monitoring, because it's a skill set as well. I wish I had a better answer, but it's certainly one of the biggest issues that come with doing these cases. The last thing before we go here, we talked about how to choose the bottom level and the top level. The top level is easier. You look at the curve, you say the curve comes around here, and then you have a cervical lordosis that comes up. You basically choose the level at the top of the thoracic kyphosis. So it's angled down, it's still in kyphosis, and then it starts to curve up. It's usually around T2 or T3, somewhere in that level, but just make sure that you get to the top of the curve and you put in screws up here. The bottom level is a little more interesting and takes a little more thought. Magogo mentioned the first lordotic disc. What does that mean? So this is kyphosis. You can see it's angled towards the kyphosis, angled towards the center. And then right about here, see this disc is angled up, and this disc starts angling out and into lordosis. So the first time that the disc comes in a different direction, like here, that's the lordotic disc. And so you usually choose the bone right below that. Dr. Lenke's paper saying that that's not always far enough down. You should draw a line up from the bottom or from the back of the sacrum straight up, and you should do the vertebral body at the top one that connects to this line. And in this patient, it's actually the same. So the disc is angled up, still angled up, and then starts angling down. That's the bone below the first lordotic disc. And this is also happens to be the same in line with this as well. And so this one comes to the same. So that's how they decided on this level. The top level is the top of the curve. The bottom level is where the sacrum passes through that bone. And so this is the T2 down to L2 here.
So do you take the level below that one, the first
No.
lordotic, or you include the first lordotic?
Yeah. So if you go by first lordotic, this is the first lordotic disc coming out of the curve, and it's the bone right there. If you go by Dr. Lenke's thought process, you draw a line up from the sacrum, and it's the one that touches the line from the sacrum. In this case, it's the same one because this is, and it's the one underneath that. And in many cases, it's going to be that exact same one. The problem is sometimes the first lordotic disc is up a little higher. And so you want to stop here, but that may be too high. And so he's saying that make sure that you're into that sacral line with your bottom bone. All right, so let me stop sharing for a minute here. Turn this off as well. All right, so thanks for, this was a long day here for everyone. It was a great day because Dr. Lenke was able to give us a talk. And as somebody said, it's not every day that you get to see a talk from the person who made some sort of classification or some sort of maneuver or something that's named after them. And they get to explain how they thought about it and how it works the best, because it's the best to hear it from the person who decided to put that on paper. You can get little nuances and ideas from them. And so that was, and it was a great overall discussion afterwards. We hope that the last 3 weeks have been good for everyone. There's been nice back and forth on WhatsApp. It's great to have these Zoom calls every week to recap in a little small group sections. Next week, we're going to go into the big group, sort of the wrap up at the end. We'll go through cases and talk about all three different types of spinal deformity, the adolescence, the early onset, and then kyphosis as well, and get questions in general about how to sort of put all this stuff together. And now that you've learned some of the basics by reviewing papers and looking at scans, but to try to pull it all together between everybody. So if anybody's got any other questions about kyphosis, I'm happy to chat about that. Otherwise, I do think that, let me see in the chat, I know that they were going to send out the link to the quiz, and let me see where that is so you guys can take it today. Let me see if Beverly sent it out. Look at the recording and then complete the quiz. Yeah, the quiz is in your WhatsApp or group A, so it's there. If you want to, at the end of this, just take that. Again, it's a quiz just to look at what the learning is, to see if it's any different than what it was at the beginning. And we'll do the quiz after the session next week as well. And they'll send you out the objectives one more time, just to see if your view on how it affects your practice and other things enters into it. So I'm happy to continue to chat. Otherwise, go to the WhatsApp and take the quiz. And we'll see you guys next Sunday with the big group, or if any of the small group sessions this week.